Thanks to everybody for coming either virtually or in person. I'm sorry that I'm not there, but it's my distinct pleasure to introduce our speaker today, Magnus Simrén. Magnus, I'll give you a brief bio. It could take all afternoon if I did the whole thing, but he graduated from medical school at the University of Gothenburg. Then he did an internship and fellowship in internal medicine and gastroenterology. He did a postdoc in Leuven, and he was actually visiting scientist with us at UNC between the years of 2015 and 2016. And then we were smart enough to put him on our faculty. So he is actually an adjunct professor of medicine in the GI division, which means he's not actually a visiting professor. He's actually one of our professors. He's currently the head of neurogastroenterology. His main areas of research are in the pathogenesis and the pathophysiology of disorders of the gut-brain interaction, including irritable bowel syndrome that he's going to talk about today. He's published 390 papers. He has supervised 21 PhD students. He has had a number of important administrative positions. He was the chair of the United European Gastroenterology, or UEG, Scientific Committee in 2013. He was the UEG Secretary General in 2018 and a member of the UEG Council. And then in terms of journals, he is deputy editor and associate editor of Gut, and he's an associate editor of Gastroenterology. He serves on the Rome Foundation Board of Directors, and he is the research director of the Rome Foundation Research Institute. So without further ado, I'd be happy to turn it over to Magnus.
Thank you very much, Bob, and thank you for introducing me, and thank you for being here in real life or online. It's a pleasure to be here, as always, in Chapel Hill. And I will spend not in the next hour, but 45 minutes or so talking about pathophysiology and how in IBS and how that relates to the modern treatments that we are using in IBS. So I will give some examples from the research that we have been doing over the past years, and see how that relates to the treatment options that we use today. So, as you know, IBS is one of the so-called disorders of gut-brain interaction, formerly known as functional gastrointestinal disorders, and these are defined based on chronic or recurrent GI symptoms that are not explained by findings on routine clinical investigations that are either normal or where the findings that you see there do not explain the symptoms. IBS is, as you know, characterized by abdominal pain and abnormal bowel habits. But there are also, as you can see here, a large group of other disorders of gut-brain interaction divided into the different organ systems in the GI tract. And the definition of these disorders is like this. It's a group of disorders classified by gastrointestinal symptoms, but they are related to any combination of these different pathophysiological abnormalities that I will touch upon during my talk. So when you think about the treatment options for IBS, just think about the stepwise treatment approach to patients with IBS, and you can write a scheme like this, where you should make a confident diagnosis, you should explain, reassure, you should give advice on diet and lifestyle and so forth. You can use pharmacological treatments, and you can, for the more severe patients, you can use a multidisciplinary approach. This is the basics for the stepwise treatment approach for IBS. And ideally, when you give treatments to patients, you should base that on a thorough knowledge of the pathophysiology of the disorder. Unfortunately, when it comes to IBS, we don't know all the details about this, the complex pathophysiology of IBS. But here are some factors that are thought to be involved in the pathophysiological factors in IBS. And as is alluded to already, brain-gut interactions are central for all these disorders, including IBS. But there are factors in the periphery of importance, but also in the central nervous system that are of importance. And some of these factors that you see over there are well-defined and well-characterized, whereas others, you can say that they are a little bit more questionable about their relevance. So what I will do here today is to show you how some of the pathophysiological knowledge regarding IBS relates to and can be translated to the current treatment algorithm for IBS. Show you some examples how actually we know quite a lot about the pathophysiology, and that has actually translated into development of different treatment options. So gastrointestinal dysmotility, we can start with that. Has for long been considered to be one of the most one of the most studied pathophysiological abnormalities in IBS. But it has been very hard to define a specific motor pattern that is specific for IBS. For instance, here you see clustered contraction in the small intestine, and they are more commonly seen in IBS, but they are also seen in healthy individuals. This is from a publication way back 23 years ago. So we have not been able to define a specific motor pattern for IBS. What is more consistent is what you can see we call transit abnormalities to the GI tract, which is more common theme for patients with IBS and other disorder of gut-brain interaction. But as you can see, this abnormal transit in IBS is only seen in a proportion of the patient. And when it comes to link to symptoms, this is specifically linked to the abnormal bowel habits in IBS. So accelerated transit is especially seen then in patients with diarrhea predominance, whereas delayed transit is predominantly seen in patients with constipation predominant IBS. So therefore, it is quite logical if you try to target transit as a treatment target, then you will probably most likely influence the bowel habits of the patient. And I will show you some example that is indeed the case. And here's an old study dating back from the 1990s, where some of the old drugs that we still use for IBS, that is laxatives and antidiarrheals, certainly influence transit time in the gut. In this here measured as whole gut transit time. So Senna accelerates transit and loperamide retards transit. And this change in transit is associated with the change in stool consistency, and also with the change in stool frequency and stool output. So by influencing the transit, you will influence the bowel habit of the patients. And there are more modern examples of this. You are familiar with linaclotide, one of the newer drugs for IBS, which is a guanylate cyclase C agonist, increasing the secretion into the GI tract. And by doing that, you can stimulate motility, you can accelerate transit. And this is exemplified here by an accelerated emptying from the right colon in patients with IBS with constipation, and also an acceleration overall in transit with increasing doses of the drugs. And this then translates to the clinical effects that we see in these patients, that is an increase in the number of bowel movements. Here shown by two outcome measures. Here you see the proportion of patients with an increase of at least one complete spontaneous bowel movements, which was higher in the linaclotide group compared to placebo. And you can also see how it affects the spontaneous bowel movements over time. So you can see a rapid effect during the first week, which is then consistent over a long period of the trial. So clearly an effect on these bowel movements with this drug affecting transit. Serotonin is one of the key neurotransmitters when it comes to motility in the GI tract. And this has been quite heavily researched in IBS, the relevance of serotonin. And the general theme is that patients with IBS with diarrhea have higher levels of serotonin and a more pronounced postprandial serotonin response, whereas those with constipation have less serotonin with a less pronounced postprandial serotonin response. And serotonin has been, as I said, been researched quite heavily and also translated into drug development. And you're probably aware of some of the serotonin-acting drugs. And allosterone is one of them, the 5-HT3 receptor antagonist. And again, you can see here an effect on transit, where allosterone retards colonic transit, measured here as the geometric center during his colonic scintigraphy. And this retardation of transit then translates into reduced stool frequency and harder stools in patients with IBS with diarrhea. So again, this link with change in transit and change in bowel habits. And the opposite is then true for prucalopride, which is a 5-HT4 receptor agonist and used for patients with chronic constipation. And with prucalopride, you can actually accelerate transit. You reduce the colonic transit time, as you can see here, and this translates then into more bowel movements in these patients with severe chronic constipation. And you see more patients meeting the endpoint of a weekly responder, that is having more than 3 spontaneous complete bowel movements per week. So I think it's quite convincing that by changing or affecting transit, you can affect the bowel habit in patients with IBS and other functional bowel disorders. And that has been, as I said, quite widely used in drug development for IBS and other bowel disorders. So one of the other key pathophysiological factors in IBS and other disorders of gut-brain interaction is visual hypersensitivity, and we and others have shown that this is relevant in patients with, in this case, IBS. Here we used balloon distensions in the sigmoid colon and demonstrated in the rectum actually, which demonstrated that they have, as a group, have lower sensory thresholds. They have increased perceived intensity to the balloon intention. They report them as being more painful, more unpleasant than healthy individuals. And they also show an increased visual somatic referral area, pointing towards abnormal processing of sensory information at the spinal cord. So regardless of which measure you use, you can actually demonstrate this visual hypersensitivity in patients with IBS and in other disorders of gut-brain interaction, such as functional dyspepsia. And visual hypersensitivity is associated with the severity of GI symptoms. And this has been quite convincingly shown in this paper with more than 1,000 patients with disorders of gut-brain interaction from different centers, from UNC, from Gothenburg, Sweden, also from Leuven in Belgium, and also using different techniques. And also, as you see from the Belgian cohort here, you can see that they included patients with functional dyspepsia. So this was done in the stomach, whereas the others were done in the rectum, but still looking at the association between presence of hypersensitivity and symptoms. And in patients who were very sensitive to the balloon distension, the everyday gastrointestinal symptoms were more severe. And that was consistent among these 3 cohorts. And if you look specifically at the specific symptoms in IBS related to rectal hypersensitivity or visual hypersensitivity, you can see that this is especially what you can think about as the sensory symptoms, pain, bloating, that are clearly most clearly associated with having visual hypersensitivity. And therefore, it's quite logical to think that if you use drugs that can influence hypersensitivity, they should be able to treat pain. And there are some examples of that, not as extensively as it is for bowel habits and transit, but still. This is a quite nice study, a small one, but still a nice study looking at the association between change in pain threshold with a balloon distension and change in symptom reports, GI symptom severity with amitriptyline, which is, as you know, a tricyclic antidepressant, one of the neuromodulators that we use quite extensively in IBS to predominantly treat pain. And you can see that with amitriptyline, you actually increased the pain threshold, which is then you reduce the sensitivity. They are less sensitive after that. And you can also reduce the gastrointestinal symptom severity. And then they assessed the association between the change in rectal sensitivity and the change in GI symptom severity, and showed a quite impressive association between these changes, indicating that if you change visual sensitivity, you can change GI symptom severity in everyday life for these patients. Yeah?
For the symptoms that are changed, are these like pain and bloating symptoms, or will they actually be like stool consistency?
Yeah,
and
they didn't look into that in detail here, but from a clinical perspective, it's, I mean, with amitriptyline, you treat pain, but of course you also should retard transit, since it's you have the anticholinergic effect here. But here they looked at the overall symptom effect. But I guess we can think, I mean, pain is probably one of the main drivers behind this overall GI symptom severity. And since we use amitriptyline quite a lot in the clinical setting, with I would say a little bit limited evidence from large randomized controlled trials, I was happy to see this trial that just came out in Lancet. Huge trial from an IBS perspective. I think if you work in other areas, you think 200 patients each group is not that big, but For IBS, it's a large trial. It's done in primary care in the UK. They used a quite low dose of amitriptyline. They didn't want to have too much side effects, I guess. And they saw quite consistent effects on the IBS symptom severity, with better effect in the amitriptyline dose and the larger proportion of patients with subjective global assessment of relief of IBS symptoms. My expectations were, when I saw this trial, was that it should have been a little bit better. I think the clinical efficacy is in the patients that I see, the more severe patients, is better than they see here. This may reflect that this is a primary care population where many different mechanisms might be involved, whereas if we come higher up in the hierarchy, we don't know that, but we can expect that visual hypersensitivity is more prominent pathophysiological mechanism. That is something that needs to be shown, but that's my take on this, because I think that the effect here was, I mean, it's statistically significant, it's there, but I think the effect in clinical practice with amitriptyline is a little bit superior to that. The dose that they used were a little bit on the low side. I always start at 25 milligrams. And if in those few patients who have side effects with 25 milligrams, I'd rather go back than start on 10 milligrams and gradually go up. But I guess this is also reflected. This is a primary care population. They want to start a little bit slower, perhaps. But anyway, good that we now have some high quality studies looking at the effect of amitriptyline in IBS and published in Lancet. Coming back to linaclotide, there is also evidence, at least from animal models, that also linaclotide has an anti-nociceptive effect. And here I won't go into details about this, but in this study in rats, they demonstrated that linaclotide could inhibit colonic nociceptors, and this was especially seen in rats with chronic visual hypersensitivity. And they could also show that linaclotide reduced the processing of noxious colorectal distension in the spinal cord. So this anti-nociceptive effect then translates quite nicely into what you see in clinical trials, where linaclotide actually also met the endpoint in reducing pain. And so you see the definition here, at least 30% worst abdominal pain reduction for at least half of the weeks, which was a secondary outcome measure, but still better effect in the linaclotide group compared to placebo. And you can also see that the effect on change in worst abdominal pain over time is better with linaclotide compared to placebo. But you can also see the quite striking difference when it comes to the effect of linaclotide on bowel habits, where you see an effect already during the first week, which you do not see with pain. There is a gradual effect on pain. We don't really know why that is, but that's something that we see in clinical practice. The effect on bowel habits comes immediately, whereas the effect on abdominal pain and bloating comes more gradually. So, okay, let's move on from visual hypersensitivity to the gut microenvironment, which is an area where many of us are now interested. It's an area where many of us are now interested. To look at the alterations in the gut microenvironment, looking at factors of importance in the gut microenvironment for symptom generations, and I will focus on some of these during the next part of my talk. I will talk a little bit about bile acids, the gut microbiome, and also about food. So these are, of course, key players in the gut microenvironment. And you can easily think that influencing these, the gut microenvironment might have effect within the lumen, of course, but also through interactions with the underlying immune system, the underlying nerve system, and influencing then brain-gut interaction. So this is a complex interaction that we don't know all the details about yet, but there are more and more studies pointing towards the importance of factors in the gut microenvironment. Now we'll start with the bile acids. From your physiology studies, you remember the enteropathic circulation, that you remember that most of the bile acids are reabsorbed in the small intestine and entering the enteropathic circulation. A small proportion enters the colon, and the bile acids, they have pro-secretory and pro-motility effects there. So it's if you have large amounts of bile acids into the colon, you have a laxative effect. And by interfering with the bile acids entering the colon, you can actually influence transit and then bowel habits of the patients, because the pro-secretory multiple and pro-motility effects of the bile acids there. And in IBS, there has been some studies looking at the amount of bile acid loss into the colon, which you can measure with the CCAT test. This is a measure of bile acid malabsorption. And the lower the value, the more you lose bile acids in the colon. So this is how the distribution of the CCAT retention test is in healthy volunteers. And the cutoff for the normal values is normally 10 or 15%. If you have below that, you have bile acid malabsorption or bile acid loss into the colon. And as you can see here from the distribution in IBS patients, you can see that there is a higher proportion of IBS patients that has low CCAT test, that is bile acid loss into the colon. And that was especially seen in the diarrheal group, as you can expect from this. And here you see this from a study that we did, that low CCAT values they were predominantly seen in IBS with diarrhea, but surprisingly also in the ones with an alternating bowel habits. And as you can expect from the well-known effects of bile acid in the colon, you see an association between the CCAT retention and the colonic transit. So with low CCAT values, that is, if you lose a lot of bile acid in the colon, you have a rapid transit to stimulate the colonic motility. So therefore, what we did in this trial, we open label, we treated the ones with a low CCAT value with bile acid binding agents and improved the symptoms, especially then the diarrheal symptoms, which can be expected. And that has also been shown in other trials with more modern bile acid binding agents, for instance, cholesevelam. And as you may know, Michael Camilleri and his group has done a lot of research on the importance of bile acids in IBS. Especially then in IBS with diarrhea, where this seems to be a very prominent factor that you can measure and then also treat. You can also do the opposite. You can increase the amount of bile acid entering into the colon by blocking this reuptake of bile acid in the terminal ileum. You can block what is called the ileal bile acid transporter, which actually transports bile acids into the portal vein and out back into the liver. And if you block this with an IBAT antagonist, then there is a greater loss of bile acids into the colon. And you can use that therapeutically for the other extreme. You can, for patients with constipation, you can then stimulate motility in order to increase their bowel movements. We did one of the first studies on this IBAT antagonist, elobixibat, where we demonstrated that with the highest doses of elobixibat, we could actually increase colonic transit, or we could accelerate colonic transit. Yeah, that's true. So accelerate colonic transit with the highest dose of elobixibat. And in a phase 2b trial, there was a quite nice dose-response correlation between the dose of elobixibat and the change in the number of spontaneous bowel movements. Unfortunately, this drug is only available in Asia. We don't have it in Europe. I don't think you have it in the US, but it's a quite effective drug for constipation as well. So you can see that you can interfere with the bile acids in order to improve transit or change transit. Now over to the gut microbiota. There are a lot of studies on the gut microbiota in IBS from our group and from other groups, and the general theme is that gut microbiota alterations can be seen in a subset of IBS patients, which was what we showed in this trial, where we saw a group of patients with IBS who had an abnormal gut microbiota composition, but we also saw a group of IBS patients who had a gut microbiota composition that was indistinguishable from healthy individuals. And the same was true, the same pattern was seen in this trial from the UK. We did another trial some years later where we tried to associate the gut microbiota composition with the IBS symptom severity. And we could identify the gut microbial signature that was linked to IBS symptom severity. And you can see also linked with some other features within the gut microbiota per se, such as low microbial richness, low methane production, etc., etc. So with this, I think it's logical to think that if you can modulate the gut microbiota in some way, you could treat certain symptoms. We don't know the details how to do that yet, but there are, as you know, several treatment options to really modulate the gut microbiota in order to improve symptoms in IBS. And here you see some of them. I will show you some of them in greater detail in the coming slides. But you can, of course, use antibiotics, probiotics, prebiotics to influence gut microbiota, and many of them have studies assessing this have actually led to improvement in IBS symptoms. I will also talk about the diet as well in the end, because that's, of course, another way to modulate the gut microbiota in order to treat symptoms. One of the most well-known examples of modulating the gut microbiota in order to treat symptoms from IBS is, of course, rifaximin, the non-absorbable antibiotic that is approved here in the US for treatment of non-constipated IBS. And here you see the pivotal trials that led to the approval of this drug, where rifaximin given for 2 weeks led to a greater symptom improvement compared to placebo. But you see the margin over placebo is quite small. It would be nice to tease out what actually what makes this, what is behind this difference. Can we identify those subjects who will respond better? But unfortunately, no one has done that yet. But there seems to be an effect anyway. A larger effect was seen in this trial with fecal microbial transplantation. And if you read this trial from Norway with fecal microbial transplantation, you think that this is it, we don't need to do anything more with IBS than to give them a fecal microbial transplant, because as you can see here, the effects are magnificent here. We see the effect size over placebo here. And they also published recently in Gastroenterology the follow-up trial where they actually could see that they could, the effect lasted for up to 3 years. I think we need to get hold of this Norwegian super donor, because they used one donor, super healthy Norwegians, who obviously this can be one of the explanations behind it. We don't know that yet, but as you know, there are also negative trials when it comes to fecal microbial transplantation. There is actually also one Danish trial published in Gut where placebo was better than the active treatment. So I think the jury is still out how effective fecal microbial transplantation is, but I think studies like this tell us that there's probably something with the gut microbiome that we can use, if not now, at least in the future, to improve symptoms of IBS and other GTIs. So now let's move over to food, which is a favorite topic of mine. We have a lot of studies ongoing when it comes to the effect of food in the GI tract, and it's also a complicated area. As you see here, this schematic drawing of how you can think about food when it comes to generating symptoms in the GI tract. You can, of course, think about different primary effects, but you can also think about secondary effects through interaction with the gut microbiome. And then through these primary and secondary effects, you can then think about influence on other pathophysiological abnormalities. So for instance, if you have a certain interaction between food and gut microbiota in a patient who has visual hypersensitivity, that might lead to symptoms. But if you have the same interaction in another individual where you don't have visual hypersensitivity, that interaction will not give rise to any symptoms. So I think this is the way you have to look at it. It's not as easy as just giving a certain kind of diet or a certain kind of microbial or modulatory treatment, and then you would get the same effect in everyone. Because I think it's about the underlying other abnormalities which can actually explain the difference in symptom response. So one of the most widely studied diets is the diet that is low in FODMAPs, and I guess you're aware of what this is. These are carbohydrates that are poorly absorbed in the small intestine. They move into the large intestine, and since they're carbohydrates, they drag water into lumen through osmosis. They interact with the gut microbiome, and that leads to fermentation, which leads to gas production. Gas and water in the large intestine leads to distension. And if you have visual hypersensitivity, you can probably feel that as symptoms. But if you don't have visual hypersensitivity, you don't feel that. So that is, I mean, there are studies now when you look at the degree of fermentation, degree of water retention in the large intestine when you give high FODMAP meal to patients with IBS and to healthy controls. And the interaction with FODMAPs is probably not different. So you have probably the same water absorption into the lumen. You maybe have more or less the same fermentation, but the patients can sense this as symptoms, probably related to visual hypersensitivity. It's a very nice paper from Robin Spiller a couple of years ago where he showed that that was probably the explanation for the symptoms. But you can reduce symptoms in IBS by reducing the FODMAP content in the food. And that has been convincingly demonstrated that by doing that, you can actually reduce the symptoms in IBS patients. The problem with this type of diet is that it is probably not healthy to eat a low FODMAP diet for the rest of your life. It's probably not good for your gut microbiota. You reduce bifidobacteria, for instance, and other beneficial or good bacteria. So therefore, after the restriction period, which could last for, let's say, 4 weeks, you should have a dietitian help you to reintroduce FODMAPs up again, up until you reach some kind of symptom threshold. Because it is probably, I mean, as you see, I mean, we remove a lot of what we call healthy diet. So that's the problem with this diet. So here you probably need a dietitian in order to really have a personalized diet in the end. But that is, I mean, that is a problem to have access to dietitians. We just finished this trial, which is a randomized controlled trial, 3 groups, 300 IBS patients, single center trial, where we use the low FODMAP diet, but we combine it with what you call traditional IBS dietary advice, focusing more how you eat than what you eat, regular meals, etc., etc. And we wanted to have a contrasting diet. So we used a diet that is low in total carbohydrate and high in protein and high in fat, which is a very popular diet, at least in Sweden, probably also in the US, to reduce weight, lose weight. And we had some patients, overweight patients who have used this diet, said that my bowel symptoms also improved at that time. So we said, why don't we use that as a control? There is also actually one trial. Doug Grossman published one open label trial in 10 patients with a low carb diet with positive results, with no control group. But there is some evidence that that might be useful. And then we had the third arm where we tried to optimize the medical treatment based on the predominant symptoms. So that's a little bit according to what we do in clinical practice today. And the results were quite striking. Both diets were better than the optimized medical treatment. When I and my colleague did the best we could with the pharmacological tools that we have, the diet was better. And this was true at 4 weeks, but we also have data now for up to 6 months where actually this effect seems to last, despite the fact that many patients go back to a more normal diet. So we think that this is some kind of, I mean, the effect here is probably due to the FODMAP diet, but then they realize, okay, when I get my symptoms, I know what to do. Then I can reduce the FODMAPs again, and then they feel in control over their symptoms. I think gradually more and more brain-gut interactions come into play here with long-term effect. That's a speculation, but we saw quite impressive results with these 2 diets. What we are doing also right now when it comes to diet is to look at what you can call intestinal allergy-like reactions in the GI tract. We use different endoscopic techniques to study local reactions in the gut. So we use these 2 techniques. This is what you call the COLAP technique, which is colonoscopic allergen provocation test, where you do a prick test in the colon, just like you do in the skin. And you look at the wheel and flare reaction. And there has been studies previously demonstrating that this relates much better to what the patient reports than a skin prick test when it comes to GI symptoms. This is something, of course, still something to investigate, but I think it's a quite interesting tool. And we also use this confocal laser under microscopy to look at the effects of when you inject different food antigens in the lumen and look at the leakage of the contrast agent into the gut. This is, when you're reading the first paper, it seems very straightforward, very easy to interpret, but it's not that easy. So both of these are still research tools, but I think we can learn a lot from what we find here regarding what we call local allergy-like reactions. But this is, of course, not only about the gut. The brain is, of course, also very important in brain-gut, in the disorders of brain-gut interactions. And this is was quite obvious, for instance, in this trial that we published together with the group in Leuven a couple of years ago, where we actually used a very simple study paradigm. We gave subjects this typical Swedish breakfast. Looks tasty, doesn't it? It's oatmeal porridge with apple jam, and it's hard bread, cheese, apple juice, and a glass of milk. Not very tough meal, I would say. But still, many of our patients had symptoms when they recorded symptoms after 4 hours. And if you divided them based on the severity of their psychological symptoms, we saw here, for instance, with anxiety, you see that anxiety, with increasing severity of anxiety, there was an amplification of the symptom severity. But with different severities of somatization, somatic symptom reporting, you can see that there is not only an amplification, you see there is also an exaggeration of the postprandial symptom response in those who have the most severe somatization or somatic symptom reporting tendency. So there seems to be also an effect on psychological factors on these symptoms from the GI tract. And this is, of course, important because we know that patients with IBS as a group, many of them have psychological symptoms as well. And that has been shown in several studies. And here I show you some of our studies where we actually saw that, of course, they have higher levels of anxiety, depression, but also GI-specific anxiety. And a substantial proportion of the patients have anxiety and or depression. And then, of course, it's logical to try to focus on treatments interfering with the abnormal brain-gut interaction that you see in these patients. And therefore, it is quite logical and very good results when it comes to using brain-gut behavioral therapy options. So this is a summary slide from a very nice article summarizing some of these brain-gut behavioral therapy options. Here you see the most studied ones, and you see the different type of mechanisms that they can address when it comes to abnormal gut-brain interactions in patients with DGBI. And as you know, there are numerous studies that have shown the efficacy of these brain-gut behavioral therapies. And we have also done some studies in collaboration with Olli Paulsson. This is one study. You know that it has been demonstrated that gut-directed hypnotherapy is efficacious for patients with IBS. But of course, this is cumbersome if you treat the patient one-to-one. It takes a lot of time and uses a lot of resources. So what we did was that we randomized the patients to individual versus group hypnotherapy. So they were treating 6 to 8 patients at the same time. And then you can see that the results are comparable in these two groups. And we are now expanding this to using, because we don't want to meet people, we try to see if we can use it online using a Zoom tool instead. And that's what this PhD student, Jan Lövdahl, together with Olli and myself, are trying to see whether that also works. And as you see here in the US, there have been development of apps, etc. And Olli has been instrumental in developing several of these online tools to use these brain-gut behavioral therapies. So they work. It's about now to get them more spread to patients with IBS. The last couple of slides, I just want to highlight. I mean, now I focused on these pathophysiological factors individually, but you can, of course, imagine that it's quite common with overlap between these different pathophysiological factors. And this is from a study that we published a couple of years ago, looking at 3 key pathophysiological factors: visual hypersensitivity, abnormal transit, and psychological distress, as you can call it a proxy of CNS dysfunction. And you can see that there is a substantial overlap among these different pathophysiological factors. And what was quite striking in this trial was that with increasing numbers of these pathophysiological factors being present, there was a gradual increase in the IBS symptom severity. So if you have many of these, you have more severe symptoms than if you have only one. And it was not only seen for symptom severity, but also for quality of life. So there was a gradual reduction in quality of life with increasing number of these pathophysiological factors. And we did the same exercise when it comes to different psychological factors. And with increasing numbers of different psychological factors being present in patients with IBS, there was a gradual increase in the IBS symptom severity. So our take on this is that we probably, at least for the most severe patients, we probably cannot only target one mechanism. We probably need to target different mechanisms. We probably need to target something in the periphery and combine it with something in the central nervous system. And therefore, I give you this extremely complicated slide. This is one of my favorite slides. It's been produced by my colleague Hans Turnblom in collaboration with Bill Grossman. I think it's actually, we don't see that up there, but when we talk about neuromodulators, we normally talk about, you think about neuromodulators with the central effects, SSRIs, SNRIs, tricyclics. If you think about it, the drugs that I've talked about, linaclotide, serotonin-acting drugs, they are neuromodulators, but in the periphery. And it's quite logical to combine neuromodulators with the dominant peripheral effect. For instance, serotonin-acting drugs in the periphery with a neuromodulator with a central effect. And potentially also, it's not called psychological treatments anymore, it's called brain-gut behavioral therapies, but this is an old slide. So you can actually target different mechanisms in patients with more severe symptoms, because if you have more severe symptoms, our data supports that then you are likely to have more of these pathophysiological factors. So I guess that's something to take to the clinic. So I hope that I convince you that by studying the interaction between pathophysiology and symptoms, we can develop better interventions for our patients, and hopefully that can lead them to improve health, better quality of life, and reduce costs. I would like to thank my collaborators. These are the main collaborators in Gothenburg, divided into different main groups, study groups that we have. We have a group that is focusing on pathophysiology and symptoms, one that is doing more on psychology, brain-gut interactions and interventions, one more on diet, symptoms and intervention, one is focusing on the intestinal allergy-like reactions, one is mainly doing epidemiology, and one is studying more clinical symptoms, outcomes, associations. And we, of course, have other collaborators that I would like to thank as well. So with these pictures from Gothenburg, Sweden, I would like to thank you for your attention and happy to answer questions if you have any. Thank you.
This is Bob Simrén. This is more of a rant than a question. And so you at the beginning described this as a disorder of gut-brain interaction. And then you spent 40 minutes talking about transit sensitivity, colonic nociception, bile acids, gut microbes, food, pinpricks. All of these are in the gut, they're not in the brain.
Yeah.
So, and then patients with inflammatory bowel disease are more likely to be anxious and depressed, and they get better if you put them on central agents. Patients with rheumatoid arthritis are likely to be anxious and depressed, and they get better. But we don't talk about rheumatoid arthritis as a disorder of joint-brain interaction. I just think this whole idea is a disservice to patients, and it diminishes the importance of the physiology. So what do you say about that?
Brain's importance to everything, all diseases where symptoms are involved. And brain-gut mechanisms might be more important for certain patients. As you know, many of our patients with inflammatory bowel disease, they get totally symptom-free when you reduce their inflammation. But we also have a group of patients with inflammatory bowel disease where we treat their inflammation goes away, but they still have symptoms. In these patients, I think brain-gut interactions are of importance. And in patients with IBS, the brain-gut interactions are of greater relevance than for IBD as a group. But brain-gut interactions are of relevance also for a group of patients with IBD. And the reason why I talk more about peripheral factors is probably that I've studied peripheral factors more than I've studied central factors. So that's maybe a bias of my personal interest, I guess.
I would just like to add that almost all of these peripheral factors affect the brain, and the brain then reacts to that. So there is an interaction there.
Yeah.
They cannot be separated completely.
No.
Right, but I think that that's true for every disease. I mean, we don't say people with heart failure have heart-brain interaction. I think that the focus should be on the gut, and that's just sort of my personal opinion.
Yeah. I mean, I partly agree with you. I mean, I think we should definitely focus on peripheral factors, definitely. But we need to acknowledge that brain factors are of importance for symptom generation in many diseases, and prominently more in these disorders of brain-gut interaction. There they are. I think they are central for IBD, for instance, or for heart failure. I guess their body-brain interactions are of relevance for a proportion of the subjects. That's my take on that.
Tyler, did you want to say something?
Yeah, I had a more superficial question than that. In fact, you talked about the pinprick allergy testing endoscopically, and I was curious what anatomic location is ideal for that, or does that depend on the patient and their symptoms, or how do you determine where you should do that?
I don't think anyone knows the best location. I mean, for practical reason, has mainly been done in the cecal area, because then you know where you are, and it's easy to stand there for a while and just watching. It's more difficult in other parts of the GI tract where the gut is moving more and you don't exactly know where you are. So I think that's more practical than logical reason why it has been done in the cecal area. But the most recent study published in Nature by Guy Boxton's group, they actually did it in Sigmund colon. And I talked to the inventor of this technique, Stefan Bischoff, from Germany. He started in the duodenum, but it was very difficult to standardize the procedure there. So then he moved to the cecal area. So I think it's more practical than logical reason why they do it.
I see. Thank you.
Francisco?
Yeah, thank you for a great talk. Do you have comments about other agents available over the counter, such as peppermint oil, psyllium-based fiber? And then have you heard of this device that is approved for children in the United States called IB-Stim? It's a retro or behind the ear electrical stimulation device to treat IBS in children.
Yeah, I mean, regarding the older agents, they are psyllium effect. There are studies that psyllium affects transit. So that could be. I could have shown that in the first part of my talk. When it comes to corpamine or peppermint oil, I don't know of any physiological studies on that, but that's maybe due to lack of knowledge. But I'm not aware of any studies there. Regarding electrical stimulation, I don't have profound knowledge of this particular technique, but there has been a lot of attempts using electrical stimulation, both to treat sensory symptoms and motor symptoms in the GI tract. I guess the most well-known is the gastric electrical stimulation for gastroparesis, for instance. So electrical stimulation has been used for different type of sensory motor symptoms in the GI tract. But I don't have any particular experience from this device that you're talking about.
All right, thank you.
Any other questions, comments? Audra?
Yes. That was a super cool talk. Really enjoyed it. I have a couple of questions. One is it in the data that you showed in your IBS patients with less bile acid absorption, were you able to identify what classes of bile acids? Was it primary, secondary, glyco or taro conjugated, etc.? And how did phosphatidylcholine change, if at all, that was assessed?
We did, in that study, we just measured the C-catas, we didn't measure the bile acid. This is actually something that we're doing quite right now.
Oh, you are?
To try to understand more about this bile acid physiology, which bile acids are mainly found there. Michael Camilleri has done a lot on that. So there is some information in his paper, but we didn't use that, measure that in our paper, in that whole study. But
how are your data shaking out, if you're able to share?
We haven't done the analysis yet. We have analyzed the bile acids, but we haven't really looking into the pattern yet. We are trying to associate that with the microbiome as well. We have a study where we have measured all the possible bile acids, microbiome, metabolome, and see how the interaction is there.
And then a second question, since I'm not very well versed in this field, but I was wondering, how does visceral hypersensitivity relate to pain perception like elsewhere?
Yeah.
Could you teach us about
That
that?
has changed a little bit over time. When I was young, and that was some years ago, and when I started in this field, there was a dogma that patients with IBS, they were hyposensitive when you tested them on the skin. But then there were larger studies done, and that was not really the case. It depended on whether they had peripheral pain as well. Then they were also hypersensitive in the skin. There is no clear correlation. It's not one-to-one correlation, but there is. In the old studies, it was thought to be more of an inverse relationship in IBS, but that was probably not true. So not one-to-one correlation. So you can be hypersensitive in the gut, but you can be not so sensitive in the skin. So it's not that they are. I mean, it's not that they are general pain sensitive overall.
I'm curious about the symptom overlap. Are there just like named subsets of IBS? Do you know that there's the constipation and hypersensitivity subset, or are they kind of still fluid, just levels of overlap?
When it comes to pathophysiology, there are of course certain factors that are more related to certain subtypes. I mean, transit abnormalities, for instance. But hypersensitivity is seen in all different IBS subtypes, for instance. But hypersensitivity, when we measure it, is not. I mean, it's present in only less 60% of the patients. So there is a substantial portion of IBS patients who are, when we blow up a balloon in the gut, they're not sensitive. And they can still report pain in their everyday life. So that's the complexity of it. So it's not. I mean, even if I said that hypersensitivity is associated with pain, it's not a super strong association.
So everything really needs to be very individualized.
Yeah, and I guess there are also other mechanisms that may be involved in pain perception. And maybe it can also differ in different areas. If we blow up a balloon in a certain segment of it.
Sure.
Yeah. Still confused, but at a higher level.
Any other questions online? I think we are good then. Thank you very much.